Right. Thank you very much. And so I will talk about possible beneficial effects of inflammation in pain control. We did see this slide already, so I'm very happy to come back to this slide because it shows there is an inflammatory soup. So there is an inflammation due to different insults like infection or physical damage, which induces activation of all kinds of immune cells and all kinds of other cells, including, this is not working, right? So including peripheral sensory endings to release substance P and CGRP. Just in response, immune cells will release numerous of pro-inflammatory mediators, which also induce activation of sensory neurons and lead to pain. So very prominent are pro-inflammatory cytokines like interleukins, various interleukins like IL-1 beta, TNF, and many others, released from macrophages and lymphocytes and mast cells. But there are also, at the same time, there are counteracting mechanisms that develop to dampen this inflammation and pain. And there are three, I will focus on three main groups of these mediators, such as anti-inflammatory cytokines, and some of them are interleukin 4 and 10, SPMs, which stands here, you have down there, specialized pro-resolving mediators, and opioid peptides. So anti-inflammatory cytokines, this is the first group that is known for a quite long time, which is released from different cells, so including endothelial cells, fibroblasts, and Schwann cells. But probably the biggest source of these cytokines are immune cells. So you see here in green, there are anti-inflammatory cytokines such as IL-4, 10, 13, or interleukin-1 receptor antagonist. And in orange, there are pro-inflammatory cytokines. So when there is an inflammatory stimulus, which is a bacterial viral infection, parasites, or tumor cells, or trauma, which is a mechanical injury, this will activate so-called resident immune cells in the peripheral tissue, which are macrophages and mast cells. And then this will lead to release of pro-inflammatory mediators, pro-inflammatory cytokines, which will lead to activation and attraction of immune cells from circulation. So there will be migrated leukocytes, releasing TNF, so pro-inflammatory cytokine, which initiates the whole cascade of other pro-inflammatory mediators, interleukin 6 and 1, and here on the left, chemokines. So these are chemoattractant cytokines, which in contrast to classical cytokines, which will activate immune cells, they will also cause chemoattraction. So they will increase the migration, extravasation of immune cells from circulation outside. And these pro-inflammatory cytokines directly acting on the receptors on peripheral sensory neurons, or indirectly through sympathetic amines or prostaglandins, they will activate sensory neurons, lead in consequence to pain. But anti-inflammatory cytokines, which will be released from immune cells, like in this case, they will not act on the receptors or on neuronal cells, on peripheral nerves. It is believed that the way they act is to decrease the production and release of pro-inflammatory cytokines. So they will decrease the release of pro-inflammatory cytokines, and this will, in consequence, lead to decreasing pain. So there are some examples of such effects. And this is one of the areas studied by a very known group, Ferreira's group from Brazil, which shows such effects. So here there is an animal model of visceral nociception induced by injection of low concentration of acetic acid into the peritoneum of the mouse or the rat. And this causes painful behavior, which is characterized by stretching of the belly, so-called writhings. And the way to quantify this pain is to quantify the number of writhings within a certain time. So here I think that writhings are counted within half an hour. So you see in the control group as saline, there are over 70 writhings, so stretches of the belly. An injection of each of the cytokines, IL-4, 10, or interleukin-13, in different concentration decreases the number of the writhings, which is the indication of antinociceptive effects. So you see that each of the cytokine decreases the effects partially. So there is an overlapping, but also limited action of each separate cytokine. And here's an example of the more recent paper published just last year where there is a fusion protein, IL-4-10 fusion protein, so the protein that consists of two cytokines, interleukin-4 and 10. And here in this experiment, the paper is quite packed with experiments. There is an example of decrease of inflammatory pain in now I think rat model. So this is the so-called complete friends adjuvant inflammation when there is an inflammatory stimulus. CFA is killed bacteria, Mycobacterium butyricum, that is resuspended in mineral oil. So when you inject this into one hind paw of the rat, it will induce inflammation like that, only in this one paw. So there will be inflamed paw, and the contralateral paw of the same animal serves as a control paw without inflammation. So here, now I have to think the effects. So the fusion protein interleukin-4 and 10 was injected intrathecally on the spinal cord. So you see here down, there were 3 injections. So after CFA, this is not really shown here, but 7, 9, and 11 days after induction of CFA inflammation, there were 3 injections of this fusion protein intrathecally, and that caused decrease or reversibility of von Frey hypersensitivity for many, many days. So in the black, you see the control group. In the red, there is group injected with the fusion protein. So for many days, for several weeks actually, this effect was reversed. So there is an example, like the authors suggest, the best is to have the single anti-inflammatory cytokine might be not so effective, and this fusion protein was actually more effective than injection of these 2 cytokines at the same time. And the other very interesting group of mediators that are anti-inflammatory and also recently shown to be analgesic are the SPM, so specialized pro-resolving mediators, or we will call them pro-resolving mediators, which are lipid mediators. And there are 3 groups, resolvins. So there are resolvins E series, resolvins D series. You see many of them. There are 3 E resolvins. There are 6 resolvins D, protectins, and one of them is neuroprotectin D1, and maresins. These are released specifically from macrophages. I mean, I'm sorry, I cannot use this. Or maybe, wait a second. Now, so here, resolvins E, resolvins G, protectins, and maresins. What is interesting is that mediators are synthesized from fatty acids here through very complicated enzymatic pathways involving numerous enzymes. And what is interesting, one of these enzymes is also COX-2, so cyclooxygenase 2. Cyclooxygenase 2 is a very important and interesting enzyme because it's a target for NSAIDs, non-steroidal anti-inflammatory drugs. So COX-2 leads to the production of prostaglandin E, and the role of NSAID is to block COX-2 and block the production of prostaglandin E2. So what might happen when NSAIDs block COX-2, they also will decrease and prevent the production of the protective mediators, so pro-resolving mediators. And in contrast, aspirin is known to actually, in few cases, so in cases of some resolvins from series E and D, you see here, can actually enhance production of this pro-resolving mediators. So this might be a partial explanation for positive effects, anti-inflammatory analgesic effects of aspirin. So what that suggests is that one has to be very careful, because by blocking pro-inflammatory pathways, you can actually also block pro-resolving pathways at the same time and prevent resolution of inflammation. So what has been believed for a very long time, and it's still in textbooks, that resolution of inflammation is a very passive process. So if you have small injury, cut on the skin, at some point there will be a little inflammation, but it will disappear if there is no chronic infection. And this doesn't happen just like this, by washing out of pro-inflammatory mediators. There is a very well organized process that leads to this resolution of inflammation. So as you see here, there can be an infection by microbes. There will be phagocytes like macrophages, and here there will be a resolvins coming into play which will promote the phagocytic action of macrophages. They will eat up microbes, and then there will be a clearance of those macrophages with bacteria, and this will lead to resolution of inflammation. Similar might happen when there is an inflammation, for instance, via apoptotic cells. So there will be, at some point in chronic inflammation, there will be many immune cells that might be apoptotic, and then if typically everything works properly, there is a very well organized process mediated by various mediators, and then resolvins will come into play. They will again promote the phagocytic effects of macrophages, and there will be successful clearance resolution. If this process is not working properly, like here, so there are mediators that become expressed, like this one, CD47, which makes or prevents the apoptotic or the removal of the phagocytic effects of macrophages. This will lead to secondary necrosis, and then release of numerous pro-inflammatory molecules where resolvins will not be able to block, and this might lead to chronic inflammation. And more recently, it has been shown that these effects might also be important for pain, for decrease of pain. So there is this paper published already 7 years ago, resolvins attenuating inflammatory pain in an animal model. Here it is caragenin inflammation of the hind paw, which is similar to CFA in that it also induces a localized inflammation of the hind paw, a bit shorter lasting. And here the effects were measured with Highgreaves test, as you have seen already before, and also in the institute in the presentation. So here the heat pain was decreased by injection of here 2 types of resolvins, so resolvin D1 and resolvin E1. Here injection was done into the paw, so directly into the inflamed paw, and what you see here, this is the time after caragenin, this is before the caragenin. Control group develops decrease or increased heat sensitivity, so decreased latency, that was partially reversed by these 2 doses, by 1 dose of each of the resolving for about 4 hours, and the effect was resolved 24 hours later. And the possible mechanism for this is the decrease of the release of pro-inflammatory cytokines. So this is shown here. So that was a cytokine array that was done on the tissue, on the skin tissue taken from the same animal. So here it's effect after resolving E2, done 2 hours. So this will be this effect. So the tissue of these animals, the skin from the paw, was removed and then screened for different cytokines. So this is what happens in the control animal. There are several cytokines and pro-inflammatory cytokines that are in different concentrations. So you see TNF-alpha, interleukin-1 beta, 6, MCP1, which is a monocyte chemoattractant protein, also called or known as a chemokine CCL2, and MIP1 alpha, which is a macrophage inflammatory protein. And then after injection, intraplantar injection of resolving E2, the levels of the cytokines, each of them is decreased. So that would be a possible one of the explanation for this antinociceptive effect of resolvins in this model. And this group actually showed in series of additional experiments, which are the other potential mechanism responsible for this antinociceptive effects of resolvins. So again, if you look here, in our inflammatory situation in the inflamed peripheral tissue, there will be many different cells. So in immune cells, these resolvins can act on the receptors. So the receptors for resolvins and other pro-resolving mediators are quite interesting group of receptors because there are several of them. And they seem to be or they are GPCR, so classical G protein coupled receptors. And one of them is hemerin, so this is the symbol in green here. So resolvins, by acting at the receptors of neutrophils, will lead to decreased infiltration of neutrophils. At the same time, by acting on the receptors on macrophages, will increase their phagocytic activity and removal of apoptotic dead cells or microbes. They also can be expressed, so receptors for resolvins are expressed on peripheral endings of sensory neurons, so you can imagine it will be somewhere here. And by acting at these receptors, they will decrease activity of several ion channels like GRPV1 channels and TRPA channels. That depends on the type of resolving or pro-resolving mediator. So different will be acting or decreasing the activity of different ion channels on the presynaptic terminals in the spinal cord. So those will be somewhere here. So the peripheral ending of peripheral sensory neurons here. Also, there will activation of the chemokine of the resolving receptors will decrease the activity of TRPV1, for instance, glutamate release, and this will lead to decreased activation of NMDA and postsynaptic, so this will be somewhere here. So there is a there are many spots in peripheral and the spinal cord nervous system in which the pro-resolution mediators can lead to decreased pain. And the last group of these mediators are opioid peptides that are produced by immune cells, and this is quite some work from our group also and other groups that actually follow this idea. And here this is a very short introduction to the opioid system. So we have 3 groups of opioid peptides, so the groups of endorphins, enkephalins, and dynorphins, and 3 types of opioid receptors, mu, delta, and kappa. So which of these peptides act at the receptor? So there is a preference here. None of these opioid peptides is really fully selective for the opioid receptors, but the preference is endorphin to mu, enkephalins to delta, dynorphins to kappa, but the N can act on all receptors. So as you know, activation of every single of the mu delta or kappa will lead to pain inhibition of analgesia, but also to numerous side effects. And these are quite selective or specific to each of the receptor. So for the mu receptor, respiratory arrest is the most dangerous because that causes, by overdosing, leads to death, sedation, nausea, constipation, and addiction. With enkephalins, in activation of the delta receptors in the CNS might lead to epilepsy-like events, and for kappa effects or sedation, dysphoria. So in contrast to mu receptors, there will be a dysphoria, depression-like effects, sometimes hallucinations, and urination. So opioid receptors are present throughout the whole nervous system. So it is known that they are present in the brain, in the spinal cord. And there are also, at the same areas, there are also endogenous opioid peptides, so endogenous ligands for these receptors. And the side effects are predominantly mediated by opioid receptors in the brain, including part of the effects of constipation and urination are also partially mediated by receptors in the CNS. But opioid receptors are also present on peripheral sensory neurons, so on neurons, on DRG neurons with cell bodies in the DRGs. So you see here, and they are transported to the central endings, so they're expressed presynaptically here in the spinal cord, but also at the peripheral endings of the peripheral sensory neurons, so directly in the peripheral tissue. And this is the concept how this can work, how so-called peripheral opioid analgesia can be induced. So opioid receptors are produced in the DRG, they are transported towards the spinal cord, but also peripheral endings of sensory neurons and accumulate here. So upon inflammation, peripheral inflammation, so when you induce inflammation here, like CFA or carrageenan, the synthesis and transport will be enhanced and they will be accumulating here in the higher numbers. So you can activate them in different ways, and one way is to by injection of exogenous opioids like morphine or fentanyl directly into the inflamed tissue in the very small doses that will not work systemically. So they will not go to the brain, but only activate these receptors in the peripheral sensory neurons, and this will lead to analgesia by acting via opioid receptors, where G alpha I, so G inhibitory proteins. This will lead to decrease or inhibition of calcium channels, also inhibition of TRPV1 channels, and this will result in decreased pain. But when there is inflammation, there are also immune cells here. So it was found that opioid peptides can also be present and expressed by immune cells. This was done in 80s. So until that time, it was believed that the opioid peptides are pure neuropeptides expressed only in neuronal cells. So we found out that opioid peptides are present in immune cells already circulating in the blood. And then they can be very actively directed through the well-organized process of extravasation using adhesion molecules. They will be accumulating in the inflamed tissue. And then when they will be activated, for instance here by CRF, I will come to this, which is a corticotropin releasing factor, a known mediator which releases opioid peptides. It will release opioid peptides just like some chemokines can do it, and the released peptides will also bind to receptors here and decrease pain. So here, within the years and many experiments, we have found that there are various mediators that can release opioid peptides from immune cells, so CRF, and paradoxically, some pro-inflammatory cytokines like interleukin-1 beta and TNF-alpha, so each of them will have the receptors on immune cells and will release opioid peptides. So what does it mean? That means when you have inflammation, so inflammatory, pro-inflammatory mediators might activate anti-inflammatory pathway like here, release opioid peptides, and the same thing can happen by activation via certain chemokines, even bacteria, and stress and surgery. So here's the example of the clinical study that was done actually a long time ago by our group to show local analgesic effects of opioid peptides in patients after knee surgery. So here you have a knee, a scheme of the knee. So there was a mixed group of patients who experienced trauma of the knee, or patients with rheumatoid arthritis or osteoarthritis, and they were undergoing knee surgery. So during surgery, the small biopsy of the synovium here was taken and analyzed here for the presence of beta endorphin and opioid receptors. So now what you see here is these cells, the blue cells are immune cells, different types. L stands for lymphocytes, macrophages, there are some granulocytes, and you see probably that some of these cells are dark brown, and this stands for beta endorphin. So you see here and here and here, there are some cells that do not have beta endorphin, so not all immune cells have opioid peptides. And in the same tissue, there is here staining for delta opioid receptors. So there's a sensory fiber expressing opioid receptors, which right away indicates there might be some interaction. So release of opioid peptides from here might act on opioid receptors on neurons and decrease pain. And this is what is shown here. So in patients after surgery, so here is the scale, visual analog scale from 0 to 70 here. And the control group undergoing arthroscopic surgery develops pain like this. It's, as you see here, mild to moderate for the first 3 hours, and then the pain resolves 24 hours later. But now there was a group of patients who received naloxone into the knee during the surgery. Naloxone is an opioid receptor antagonist. So what you see here, when you block these receptors here, opioid peptide like beta endorphin cannot really access the receptors, and the pain is increased for 4 hours after one single injection. So the idea here was that during stress related to surgery, opioid peptides are released and endogenously decrease the pain. What that means is if there are no opioid peptides and receptors active here, the pain after surgery would have been stronger. So the pain is still there, but weaker. And here's also an example how we can increase the activity and the level of opioid peptides in peripheral tissue, the peptides, opioids coming from immune cells. So peptides, opioid peptides are peptides. They are degraded by various peptidases, so they don't stay long in the tissue. They are degraded very fast, and they are degraded by two peptidases, aminopeptidase N and neutral endopeptidase. We found that they are expressed, the peptidases are expressed on peripheral sensory endings, but also on various immune cells. And now in this model, again CFA, by using pulse pressure test, what we did, we injected the peptidase inhibitor, so-called dual peptidase inhibitor, and substance that blocks both peptidases here, directly into the inflamed pore. So what you see here, that's the situation before injection, so that's after CFA, inflamed pore, stronger pain than the non-inflamed pore, and injection of this inhibitor reverses this and brings the threshold a bit higher than non-inflamed pore. So the effect is not very strong, I would say. Like for this test, the effect is not extremely strong. It's higher than the non-inflamed pore, and our collaborators that we worked with from France, led by Bernard Roque, who now funded Pharmalis, the company, they actually started testing similar dual inhibitors in phase 2 and phase 2 clinical studies for pain. And their idea is that these drugs will not be very strong analgesics, but they will be weaker as classical morphine or fentanyl, but hopefully stronger than NSAIDs, so they might be somewhere in between. And so here also, how can this be that immune cells at some point can produce pain, release pro-inflammatory mediators, and then they can release opioids and decrease pain? So how does it work actually? So we know now that immune cells are not very homogeneous populations. So we have T cells, we have neutrophils, we have macrophages, but on top, each of this population consists of several subpopulations. And here is an example for macrophages, that macrophages are very heterogeneous, so there are at least two subtypes, so-called M1 and M2 macrophages. And M1 are pro-inflammatory macrophages, which will be activated by mediators like pro-inflammatory mediators, lipopolysaccharide. They will release pro-inflammatory cytokines in very high levels and express inducible nitric oxide synthase. And anti-inflammatory cytokines M2, they can be activated by interleukin-4, anti-inflammatory cytokine, and they will lead to release of other anti-inflammatory cytokines like IL-10 and decreased release of pro-inflammatory cytokines. So we recently have shown that it's not only anti-inflammatory cytokines that play a role and are responsible for M2 macrophage analgesic effect, but also they have more opioid peptides. So we have stimulated the cell. The process is called polarization. So you incubate the cells from the bone marrow with these mediators that I showed here before, either LPS or with IL-4. And then 2 days later, we measure the cells, and we have the control cells that are unstimulated, M1, pro-inflammatory. You see they have less opioid peptide, in this case methencephalin, and M2 have higher amount of enkephalin in the cell. And they also release more. So when we keep the cells for 24 hours and then take supernatant, extracellular supernatant, we see the M2 release much higher amounts of enkephalin than M1 particularly, and even more than M0. And now when we inject this M2 macrophages exactly here, so that's the model for nerve injury, chronic reconstruction injury. So now inducing the CCI causes the decrease in the threshold, so that's the von Frey filament threshold that leads to hypersensitivity. Now 2 injections of macrophages at 14 and 15 days later will lead to decreased sensitivity. So now the effect is not fully reversed. It's a partial effect, I say, because the threshold before injury would be here. So that's the partial effect. And it is mediated by opioids, because injection of naloxone methionine, which is a similar antagonist to naloxone but working preferentially on peripheral receptors, will decrease this transiently because it's a short-lasting effect, but it decreases it, suggesting that this effect is mediated by opioid peptides and receptors. And then when we inject that M1 macrophages or M0 macrophages, we had no effect on the threshold, so there was no decrease in hypersensitivity. And the last example is very recent, that not only opioid peptides can be released from immune cells, but also opioid receptors on immune cells can mediate analgesia. So the idea here was that we have opioid receptors on the nerves, so there is DRG. They are transported toward the peripheral endings. When there is a damage to the nerve at the trunk, they will accumulate and express in higher levels here. But there are also, because that's the damage to the nerve, so any damage to any tissue will initiate the immune response. And there will be immune cells accumulating here. They will release opioid peptides. Possibly we had this idea when we activate also opioid receptors here. So we found that opioid receptors are also present on immune cells. So their activation by ligands such as DAMGO, which is something similar to morphine, exogenous opioid, will release opioid peptides that will act at the receptors, neuronal receptors, on the peripheral endings and decrease pain. And that's an example how we have found it. So So here you have the threshold before the injury, so that's again the CCI model, and 2 or 14 days later, the threshold is much lower. When we inject Damgo, which is a mu receptor agonist, here directly at the CCI site, we have full reversibility of hypersensitivity, but now when we remove or decrease the immune cells from here, from the nerve, the effect of Damgo is much weaker. And then this effect we can reverse by re-injecting immune cells from wild-type animals back together with Damgo. But this does not happen when we take immune cells from mice that do not express mu receptors, so mu knockout mice. So when you see here, when we put back immune cells, but they don't have mu receptors, the effect of Damgo is just like here. So this is the indication that opioid receptors on immune cells do play a role. So are also involved in analgesic effect. And that's the very last slide, comparing the mechanistic action of opioid receptors in neurons versus immune cells. There is a different, slightly different mechanism. So typically, as I mentioned before, on the neuronal cells, opioid receptors, activation of opioid receptors by opioid, either morphine or endogenous opioid, will activate the G protein, so that the G alpha I coupled receptor, it will increase or open potassium channels, which leads to hyperpolarization, will decrease or block calcium channels, which now will lead to decrease of release of pro-inflammatory, pro-nociceptive mediators such as CGRP and substance P, and in consequence will silence the neuron. So immune cells, opioid receptors on immune cells are the same opioid receptors. They are also G-alpha coupled receptors, but when we activate them, what happens is the whole process is mediated by intracellular calcium. So beta-gamma subunits of G protein will activate phospholipase C. This will lead to increased production of inositol 3-phosphate, which will activate the receptors on endoplasmic reticulum, cause the release of calcium, and this will lead to the release of opioid peptides, and this how it will contribute to antinociceptive effects. So in the conclusion, I would like to say that inflammation can be beneficial. It doesn't mean that one has to induce inflammation to decrease pain, but if there is inflammation, there are processes that are active, that are actively try to counteract inflammatory pain or pain associated with, or other types of pain associated with inflammation. So including anti-inflammatory cytokines, pro-resolving mediators such as resolvins, protectins, and maresins, and opioid peptides and receptors in immune cells. So what that means, if there is an unspecific, general anti-inflammatory treatment that will decrease or inhibit all immune cells, this also will harm beneficial actions of inflammation, and that's why what is important but extremely challenging is to selectively target these beneficial actions of inflammation, and that's very challenging. So how to do it is very difficult. So I showed an example for fusion protein of anti-inflammatory cytokines. There are some effects or tests, clinical studies with single injection of either IL-4 or 10 in patients with rheumatoid arthritis, which was not very well working. So now there is a suggestion that if there is a molecule that can combine the effects of both might be better, or promoting an effects of pro-resolving mediators, which is a quite big movement now. And there are some clinical studies, but not in pain, in inflammation of the eye and tooth inflammation. And with opioid peptides, it's the same way, find a way to selectively activate immune cells containing opioids. So you might hear a bit more about this tomorrow. So there is a new opioid that we found that might act only after systemic injection, because that's the important thing. will act only in the peripheral tissue. And all of this might lead to fewer side effects. So for instance, immunosuppression might be avoided, immunosuppression caused by steroids and NSAIDs, when we target resolvins. And in case of opioids, the CNS effects should be also absent. And here is the group, so our group from Berlin and our collaborators who contributed to the opioid part. Thank you very much.